Welcome everyone to another presentation on the OrthoEvidence Insights World Tour. Today we are now visiting Colombia virtually, and I'll share with you a little bit about our speaker in a few seconds. But let me first introduce myself, Mo Bendari, Editor-in-Chief of OrthoEvidence. And as some of you know, who have been involved in this, some of these other events, these are small, deliberate small events that we use to have more like conversations than anything else, rather than the standard large webinar series that we run in other venues. Let me also remind you, if you don't mind, to stay muted and off video while our speaker is presenting, but we will encourage you to come back on video in about 10 to 15 minutes or so, where we'll have a 15-minute discussion with our guest speaker. So do keep that in mind. Also, if you are finding these types of interactions helpful, do go to the website and take a look at some other presentations that are coming up tomorrow. There's a few more left in our 4-day series, so tomorrow is the last day of our tour. We'll be back again next year, I'm sure, with more speakers and certainly additional insights. But on this note, let me introduce a colleague, a friend, a collaborator, Professor Carlos Leal, who, as you can see here, is heavily credentialed and primarily has had an interest, as you can see here, in the shockwaves in orthopedics. And we're going to hear his story about this long and winding road. And I do hope it will spark some questions and some discussion thereafter. Carlos, welcome.
Thank you, Mo. I'm going to share my screen now. Let me know if it's okay and if it's showing.
It's working great. Good? Yep, superb.
Well, thanks, Mo, and it's a great pleasure and a privilege to be with you guys here in this world tour, sharing a little bit of what we have done in this past half century, actually, in this long and winding road of shockwaves and orthopedics. It's a new technology, but remember that everything that is new is not always good, but everything good was always new someday. So it's amazing that after half a century, it's still believed as a new technology. So let me share with you a little bit of what has happened. My home is here at the Universidad del Bosque University in Bogota, Colombia, 2,600 meters closer to the stars. But my second office is in Austria, actually. I'm the scientific secretary of the International Medical Shockwave Society, International Society for Medical Shockwave Treatments. It's in Vienna. And we have been able to witness with the ISMST the fascinating journey of lithotripsy in the 1980s that started like extracorporeal shockwave lithotripsy. That was defined as the use of this focalized high energy sound waves for kidney stone fragmentation. And from then, in 1980 until now, in 2020, we're working the concept of extracorporeal shockwave treatments, which is something really different. It's the use of a regulated, localized mechanical stimulation for medical and regenerative treatments. And orthopedics really has put a big brick on this new pyramid of knowledge. But it's been a long and winding road. I mean, it's been something that has come from the 1980s in lithotripsy to the 1990s with the first high energy devices and experimental devices all over the world, to the most recent in the 1990s evolution of more portable devices, not much like the lithotripters that you see in hospitals. And then in this last decade, all the coming of new radial pressure devices, more portable and more versatile, really, devices that we can use for different applications. So it has been a long and a winding road, as you can see. We can for sure know that we can look back and understand that everything that we have done so far has been very interesting, and that we have really given something to science. And how did it all start? It's quite a story. It came out as a simple hypothesis that you can bomb and pulverize kidney stones with focalized high energy sound waves. And this actually started in Munich in 1969 with this extraordinary smart urologist, Dr. Schmid, Dr. Schossi, Dr. Hocham. And these three people were, they worked with the German government and the University of Munich. And they wanted to know what would happen if you use high energy and shockwaves or ultrasound to destroy this kidney stones. It actually started in 1969, and it took 11 years until this day, a very important day for us in Shockwaves. Thursday, February the 7th in 1980, the first treatment of lithotripsy happened. First patient was treated. And from that moment on, what you have seen is that millions of people all over the world have been treated and still are benefiting from this non-invasive technology. Some things in urology have changed, endoscopy, surgery, robots, and they're very good with technology. But still, millions of people have been treated and still benefit from this technology. So what happened with the researchers in those days, and that was quite kind of a funny story. When you had a very low kidney stone in the urethra, and you had to use the lithotripter going through the iliac bone, then what we could see is that there was an increased bone mineral density, or bone density at least, of the iliac bone in the x-rays. So the question arose, maybe shockwaves can increase bone turnover? And that was the first research questions that we had, maybe to use this technology in orthopedics. Because if you could really get more bone turnover, you could use this for important things such as delayed unions or non-unions. And then the second question was coming out of the sports medicine people. So if you have a technology that destroys kidney stones, maybe you're able to destroy tendon calcifications or maybe bone spurs. Why not? Can you use it here in calcified tendinopathy of the shoulder, or maybe here in a heel spur? That's a very interesting question. Actually, those were the first research approaches to using shockwaves in orthopedics. So we started doing this back in the 1980s. And in the 1980s, it was sad to see that only half of the patients had their calcifications removed, and the x-rays were pretty much the same. But the good news was that there was very significant pain control, and the function improved significantly. And these results prevailed for many, many years. And there were no complications related to that. So it was a big research question coming up. Because if this was just a pain therapeutic device, well, the pain would come back, but the function also improved, and it really lasted for years. So there were many questions, and the fact is that when everything started, our early leaders that were the European Society for Musculoskeletal Shockwave Therapy, the EFMST, well, they didn't really know what they were facing. They didn't really know what was going on. They just wanted to use the same principles of lithotripsy into bone and into tendons, and to see if they could answer those two questions. Maybe we can have some bone turnover enhancement with shockwaves. Maybe we can have some tendon calcification control with this. But there were many, many questions. The fact is that lithotripsy principles, those were the protocols and the general principles of what we would use in musculoskeletal indications. And as you can see, this is one of the patients from Dr. Palacio here in Medellin, in Colombia. Those were the first patients all over the world using huge devices, huge drums with a very high energy trying to heal bone. And actually it worked sometimes, but those were not the energies required. The fact is that no biology research was required for lithotripsy. It was only a mechanical and an engineering approach to destroy and to focus all the energy in the kidney. The good thing is that it was safe. Even with that very delicate tissue, you caused almost no harm. So in the beginning, everything was mechanical. We thought, I mean, we're orthopedic surgeons from past century. If you have a bone that has a fracture and didn't heal, well, you refracture, so you re-heal. So this was causing microfractures, so you would do micro healing, and then you will end up with the full healing. And actually, this first approaches that you see here from Dr. Rompe, those were microfractures in rats using huge devices with a lot of energy. And that's actually nothing that we could explain. So why did this work? If you have a patient like this, where you have 6 months after surgery with no healing whatsoever, and then 6 weeks, this is 6 months after, this is 6 weeks after Shockwave, and you start having good healing, and then 12 weeks after that, you have a huge, huge callus. There's really no way that you can explain this phenomena just with a mechanical model. It had to be something going on there that was just not mechanical. And then the histological findings were also very interesting. You can find, as Dr. Shadden described in those years, that three weeks after high energy Shockwave application, you had a very highly active osteocyte and osteoblast activity. And then you have bone formation and new bone tissue. And it was not because of microfractures. This was like some kind of cell stimulation that we didn't understand in those days. Dr. Jean-Dirk Compa from Mainz also worked not in bone, but in tendon. And back in 1998, he published in the JBJS this very interesting histology where you see that after 1 day with high energy, you have a very, very high inflammatory reaction. But most interestingly, after 7 days, you started having a lot of cell migration and differentiation, and then you had new blood vessels, tiny little capillaries. And that was something that really changed everything. And we didn't realize that. It passed more than 7 years until we had this meeting with Dr. Tariq Mourad, a Nobel Prize in Toronto during our ISMST meeting. And he said, oh God, you're orthopedic surgeons, you only think mechanics. You're creating new blood vessels and you're creating migration and differentiation. We're going to use this in heart. We're going to use this in bone and in skin. And it really changed even our society. It changed from musculoskeletal society to a medical society. And that was a breakthrough. What do we know right now? That there's an extremely complex cascade of intracellular and molecular reactions that are caused by ESWT. Extracorporeal control, mechanical stimulation do create a cascade of reactions. So we have to sit down and learn shockwaves. We have to sit down and study this with physics and study this and behavior and understanding how did we deliver the shockwaves and the two effects of it, the energy distribution of the impact that you can cause with a shockwave, and understanding very well the physics of how you deliver that focused energy or that pressure energy, and understanding cavitation. That is also a very interesting way of stimulating cells. Once you have a very high reaction or a focused reaction, in this focus you create a lot of bubbles that also generate certain changes within the cells and inside the cells. So we have to learn also biology and understand very well what does happen in every tissue and in every cell when you stimulate them with a high energy or some kind of mechanical stimulation. And then the magic word of mechanotransduction came through probably 15 to 12 years ago. If you see the nice publications and papers from Jaluk and Wang, they basically show all the receptors that you have in the cell membrane and all the reactions and all the stimulation that you generate, the RAS systems and pathways, all the calcium and activation of transcription factors, and everything that is produced in a cell just with physical stimulation, not mechanical. Mechanical, but not only chemical stimulation. So it can be both direct or indirect. And those have been studied not only with positive mechanotransduction, but negative mechanotransduction by NASA, for example, in zero gravity situations. So what do we know right now? We know that shockwaves stimulate all the processes of tissue regeneration and healing. There are two major pathways. One is vasculogenesis and the other is cell migration and differentiation. You create blood vessels, and you also stimulate the cells to do what they are used to do when you heal, which is migrate to the place where the healing is required and differentiate in the adult cell. We didn't know very much in the past years, or in the last 2 decades, actually, what was going on. You knew the effect, you knew how you produce the effect, but you didn't know the in-between. Now we know that it's the stimulation of endogenous growth factors, all the mediators, the intercellular mediators between cells, and the gene expression modifiers. And that's exactly the same thing as what we're doing with the implant of mesenchymal stem cells, for example. There's a lot of studies from the ISMST, both in Germany, Austria, and in Taiwan from Dr. CJ Wang. And we have learned that the gene expression is the key for shockwave effects. And how can we prove that, actually? We have to go and analyze the tissue regeneration biomarkers for angiogenesis, osteogenesis, proliferation, and in the same way as any other regenerative therapeutic. And this is what we have found. I mean, there are basically three major expression markers for shockwaves that we study. The ENOS, the vessel endothelial growth factor, and the bone Willebrand factor expression. Now, what we see in all Wang studies, and we have seen also repeated in other labs, is that before and after you apply shockwaves, you have a very nice and positive expression of all these factors. You see von Willebrand, which is a good indicator of new capillary formation, as well as ENOS, which is a very powerful immune system intercellular transmitter, as well as VEGF. All of them express highly and significantly after shockwaves. This is a marker for vascular permeability, which is very important. So those three factors are very interesting. Plus, there's another one, which is the microscopic features of the new vessels that we create with shockwaves. You compare the befores and afters in tendons and in tendon bone junctions, you will find that there are new blood vessels, and we're creating actually new capillaries, which means that this is what happens. You bring new blood vessels, you bring new blood to places where they used to be no good healing, like the insertion of the tendons and many other places in the human body. The stimulation of pericytes, which are really the stem cells of capillaries, they respond very well to mechanotransduction. And those are the ones that are responsible for creating new blood vessels and new capillaries and new angiogenesis. So what CJ Wang, the professor from Taiwan, published in JBJS in 2005, is still valid. And when you apply physical shockwave energy, you get a biological response. You generate answers from these cells, and you produce new vascularization with better blood supply, and you end up with good bone repair and tendon repair through tissue regeneration. And this is something that has 15 years now and is still valid. We can conclude that shockwaves do promote tissue regeneration in those ways. New blood vessels, tissue cell migration and differentiation. That is a pretty clear way to work. But then we have to learn how to apply this and how to design new devices that you could use easily for different applications. And if it really would work, we got all the basic sciences, and now we have to go out there and prove it. This is me in August the 9th in year 2000 with the first patient done probably in America, the first one in Colombia, for a non-healing of tibia with a huge device and a huge body. And now with a smaller device and a smaller body, we're working with the new devices that you see here that are more flexible, that are versatile, and they give the proper energy, and they're not painful. Basically, there are two different types of devices for shockwaves: the radial or radio pressure waves that deliver the energy right in contact, very, very close to the skin. And then you have the focalized or the focal shockwaves, which are the real focused ultrasound, high energy devices that deliver the energy far away from the application point. And our job at the ISMST is to produce consensus statements and indications and study very well how the evidence is to declare one indication as approved and standard. And as you see, we have chronic tendinopathies, basically all the sports medicine tendinopathies, bone pathologies, and skin pathologies. Those are the three approved standard indications, and we're working for there. What do we know now? That ESWT in sports medicine is pretty common. It's the 85% of the indications and applications all over the world, basically in tendinopathies and stretch fractures. This is a regular standard. It took us 20 years really to be included in the protocols and the treatment options for tendinopathies all over the world, but it's working right now. Everybody's considering them, and the results are pretty good. you just see as this quick numbers, this is statistics from Asia and Wang, America with Pierce, Germany and Europe with Schaden, and this is ours. Basically, what you see is reduction in pain in yellow and then functional scale in blue. We're all pretty much the same. So it's very consistent. If you compare this with just physical therapy that's very low and with surgery, it's almost lower, always significantly lower in results in long term. So it's not only good, but it's reproducible and you can use it very safely. How about bone? We use it for delayed unions, for vascular necrosis, and now there are new projects for osteoporosis. So you see, this is a typical example, patients with 2, 3, 4 surgeries, a big osteoporotic bone, and then after the shockwave therapy, 6 months, you have these patients again, and this particular patient we found on the streets in Austria. This is Dr. Schaden's patient, and he ended up playing soccer. And found him playing soccer 6 months after shockwave therapy. Maybe one of the best papers is from the group from Caccio and Dr. Rompe. And this is basically the first randomized clinical trial comparing surgery versus shockwaves in non-unions. And the results are really good because the level of evidence is therapeutic level 1. And as you can see in that fight, the shockwaves were better. 70% of union in all groups, both groups, surgery and shockwaves. There were no differences between surgery and shockwave therapy at all. There were no differences between the 2 shockwave therapy protocols that were used. They used 2 different protocols, basically. And there was a quicker return to function after shockwave therapy and no complications, no severe adverse effects after shockwaves. And you had more severe adverse effects after revision surgery, and the cost was a lot higher. The next level of research is working with osteoporosis, and this is the project from Marianne Poulin and Wolfgang Schaden. Probably understanding that we can create better healing and prevent fractures just using osteoporosis, and prevention is another step, and we'll probably be working on that. The other level of work is skin. The indications are diabetic foot ulcers and wound healing. And we have just opened a new window for aesthetics in the past 5 to 10 years. And it has grown rapidly for cellulite and for scars and wrinkles. So in skin, we have also very good applications. In pain, that is one of the major objectives in physical therapy and rehabilitation. They're very, very good work in trigger points. The late work of Dr. Tommy Nedelka from Praga in facet lumbar pain is extraordinary and a fascinating work. And we're also working in knee osteoarthrosis. We don't cure osteoarthrosis so far, but we're able to work in pain and have very nice protocols for patients that cannot have surgery, like a total knee replacement. In nerve, it's a very promising field, not only in peripheral nerve repair that we've been working for years, 20 years maybe. There's a very clear enhancement of nerve repair when you do a suture of a nerve, but the real challenge is in medullary regeneration. There's a very, very nice work from Johannes Holzold and Go Tepanyok. I never know how to say that. Tepanyok, we call him just Ken. And from Ken and Johannes, they have a very nice work in Shockwaves promoting spinal cord repair. And there's a very nice work now going on in Germany, Switzerland, and Denmark with transcranial shockwave therapy for really interesting protocols in Alzheimer's, in Parkinson's, and probably also in migraine. In heart, the first approaches were with extracorporeal, and this is probably the future. It's the first human shockwave application in September 2008 by Wolfgang Schaden in patients in the United States. And it really improves healing. When you change the plumbing of a coronary artery, it changes the blood flow, but you can really improve healing and cell migration and differentiation with shockwaves. And this is a protocol, this is a base for research. In urology, it's used for erectile dysfunction apparently with a very, very successful past and future, and it's still being used all over the world. And these are the exceptional and expert indications, and all the experimental indications we're doing now, from dental to cardiovascular, from lymphedema to infection, from bone growth and bone mass to muscle enhancement. It's a very, very interesting field, and we're working on all of those. So it has been an interesting journey, a fascinating journey. These are the first patients that we did 20 years ago in Colombia with all the indications with huge devices. It's been painful. Somehow we've tested it, we've used it, we've grown. We have tried to open the door for all people. And after having just one center in Colombia for almost 10 years, there's more than 42, and we have 216 members in our society. But we have to learn a lot, learn from the experts like Dr. Shadden here, teaching us how to work on bones here in Bogota. And our job at the ISMST, which is learning and teaching as much as we can, doing workshops, training people, and trying to give the pathway of this fascinating technology, because it's something that is harmless. The worst thing that can happen is that nothing happens. And it's a fine line between just physical therapy, where you can work with physical therapy, and then avoid going to surgery in many, many things that are not mechanical but biological. So what can we say now? I think that the protocols of ESWT are not kitchen recipes. Everybody asked us, what's the energy, what's the frequency, what are the sessions, what kind of device you can use. It's not that easy. Maybe you can use old devices like this that are powerful for pain, but not great for regeneration. But what we know is that we're able to prove ESWT can cause favorable healing. And our big conclusion is that we have, after 20, 25 years of clinical use, a very high efficacy, mostly good outcomes. We're over 75 to 85% in most of the applications in soft tissues. It's a safe procedure. We have minor or no complications. We don't have major adverse effects. The mechanisms are biomolecular. They're not just pain control. It's just the major expression of mechanotransduction. We still have a lot of research to do. We have to study all the cell responses in different tissues, and we have a lot of things to develop. We need to standardize all technologies. We have to standardize all protocols, and that's a good thing, because us, the researchers, will still be working for a while. My conclusion is that probably the main achievement of shockwave therapy in orthopedics has been our contribution to create a regenerative medicine tool from a stone destruction technology. So thank you, and I hope you had a good insight out of what we have done and we have learned in this 40 years, and I hope you have a lot of questions. Thanks, Mo.
That was fabulous. Thank you so much for the very clear storyline, and clearly demonstrates the amount of work and energy you've spent trying to sort out this problem. We're all actually quite near the end of our session, but I wanted to make sure we have a few minutes just to make sure if anyone has any questions for you, Carlos. So for those of you who feel comfortable coming back on video, please do. You can feel free to ask a question or two. Let me just simply just begin by asking you this. When you look at all of the indications and your experience with shockwave therapy, what for you do you feel is its absolute defined indication? One where you feel it's had its greatest mark, or it's made its greatest mark?
I think the three of them. I mean, both in every field: in skin, sure, diabetic foot ulcers; in tendon, insertional tendinopathies, which is basically like a heart attack of the tendon. It's like a heart attack in your elbow, or just a vascular problem. So tendinopathies. And definitely in bone healing with delayed unions and non-unions are great.
And you've tried them for all these indications. So, for example, when we talk about in comparison to other types of technology, so I suspect you're probably also aware of some of the electrical stimulation, low intensity pulsed ultrasound that's being used, also having a little bit of a mechanical and biological effect as well. How does shockwave therapy compare with those other modalities that are also used for fracture healing, Carlos? Are you aware of some of those comparisons that are being made?
Yes, I think that these are all mechanotransductional things, and both thermal electrical, magnetic, and mechanical. And out of those four, I can tell you that mechanical forces are much, much better for bone healing. In terms of pain, it's very similar to electromagnetic pulses. And in tissue regeneration, I think that still these mechanotransduction effects of shockwaves are much better. We use multi devices, you know, like the one that you see behind me. You see laser, you see radial, you see focus, and now we do have also for pain we have electromagnetic stimulation. So I think that at least for tissue regeneration technology in healing, mechanical language is still the language of the musculoskeletal system. So that's why the mechanical forces with ESWT are probably better for that kind of purpose.
Oh, interesting. Is there any ongoing clinical trial work going on? You nicely presented the JBJS trial as one of the benchmark trials for its use. Have you been any other trials ongoing as it relates to orthopedic indications?
Oh, many. In sports medicine, you have many trials going on, and in bone, especially the Schaden group has more than 10,000 patients now in Austria, and it came out to a point that if you have a delayed union in Austria, the government and the insurance companies probably will consider first the shockwave therapy before going to surgery. There are many trials going on right now, and that's what we need exactly. We need more data because, you know, this is a very fragile technology.
Sure.
Everybody can use it because it's harmless. So you have a variety of protocols. Our job in the society is to make everything as close as possible to evidence, as close as possible to parameters that we can define, so we can share our systems and our answers.
If there's no one else that has a question, maybe I'll ask one final one before asking you to maybe have a closing comment for us. Actually, there is a question. Okay, Sebastian.
Hi. I was wondering, because around my area, there's mostly mechanical unfocused shockwave that is available. And I was wondering, in terms of result, would it give a similar result to focused shockwave therapy, or is it not as valuable in terms of treatments?
No, unfocused therapy is used basically for skin. And that's what we were using with very good results. At the beginning, we used to treat patients that had skin problems and had a fracture. And then we found out that the skin got a lot better. And when you use it for diabetic foot ulcers, when we use it for any skin applications, the best way is to have an unfocused or a planar type of device. And that's what we use. So your field of work is skin, or what do you work with?
In sports medicine. So
in sports medicine, you could use unfocused or at least the flat type of devices. You get much better results if you're able to focus exactly in the places where you need to get rid of the pain. Most of the devices that are used in sports medicine now are radial, that are not the unfocused, but the radial type of devices that just deliver pressure on contact. The good news is that most of the tendons are just subcutaneous; they're not even an inch in depth. So you could get good energy with a radial device that just produces pressure. Doesn't create a lot of cavitation. We have not been able to prove it. But in large tendons and in large problems, we prefer to use focus. But you can certainly use the unfocused device. Is not unfocused, but a radial pressure device.
Great.
Okay.
Okay. Thank you.
Great. Thanks, Sebastian.
Sure.
Anyone else have a comment or a question? Okay. Well, listen. Realizing that we want to keep people to the time. We want to respect the 30-minute session. We've got a lot of information. We'll make sure that we get this edited and sent out to the wider community as well for you, Dr. Liao. But just in closing, is there any final comments you'd like to make regarding this presentation, or any future areas of inquiry that you'll be exploring?
Well, I've been very privileged to be part of the growth of Shockwaves. I got into this technology to prove it didn't work. I found it did work. And I found that during this 40 years, it has been actually growing and growing in specialties and growing in the effects of mechanical forces in the tissues of a human being. So I'm expecting a lot of future. I'm expecting a lot in nerves. I'm expecting a lot of future in the rest of the applications. So you will be hearing a lot. I mean, it's been 51 years actually since the first approach to using high energy shockwaves in the human body. And that in medicine is very short. So expectations are high, and knowledge is growing and growing. So we just need to get more and more people interested in something that is really science, and is not just something that is alternative medicine. This is real science.
Well, I can't thank you enough. Thank you all for attending this session, and we look forward to hearing more as this story progresses, Dr. Leal. Thanks again, everyone. Have a wonderful evening or the rest of your day.